Well, good evening, everyone. Thank you for joining us this evening for the inaugural Doctors for America Advocacy Grand Rounds event. I'm thrilled that you all have joined us and that we have such amazing speakers and an amazing topic to start us off, introducing advocacy messaging and framing to our community. This Advocacy Grand Rounds series has been designed as sort of a mimic of the clinical grand rounds that we're all familiar with, but with a health advocacy spin. And our hope is that will be a training opportunity and provide material that can supplement the advocacy efforts you're already doing in your communities. And that it will also provide an opportunity for you to connect with other doctors, medical students, luminaries who are doing health advocacy work that interests you. And with that, I'm going to introduce our DFA speaker and Q&A moderator for this evening, Reshma Ranachandran. Reshma is a National Clinician Scholars Program Fellow at the Yale School of Medicine. Prior to this, she worked at the Innovation and Design Enabling Access Initiative at the Johns Hopkins Bloomberg School of Public Health, where she focused on antimicrobial resistance and access to medicines. Reshma serves as the co-chair of the National Steering Committee for DFA's Drug Affordability Action Team, and also as a board member of the university's Allied for Essential Medicines North America. And Reshma will start us off this evening. So with that, I'll hand it over to you, Reshma.
Yeah, thanks so much, Justin, for this first in a series of Advocacy Grand Rounds. We can go to the next slide. So I'll be specifically speaking to advocacy and framing from the viewpoint of a health professional, and specifically on messaging and framing, and how we as health professionals can actually take our passion and also our frustrations with the healthcare system and channel it towards effective messages to different audiences. So we can go to the next slide. Just some disclosures. I don't receive any pharmaceutical or medical device company monies, or really any sort of health insurance or any health product monies whatsoever. The work that we do with the Drug Affordability Action Team is funded by the Laura and John Arnold Foundation. And we have a really great group of physicians across specialties from around the country who are united in their efforts in wanting to make sure that affordable and accessible medicines are made available to all patients regardless. Next slide. So just want to take a step back first and talk about our role as health professionals and kind of the responsibility and the opportunity that we have in terms of being advocates and also framing these messages that we care about to different audiences. So this is from the Gallup poll that's done every year, where different professions are assessed in terms of their honesty and ethical standards. People give their opinion about how honest or ethical they feel each profession is. And for the last 19 years, nurses have actually topped this list as being viewed as the most honest and ethical profession by far. We're as physicians, we're actually number 3. We fall under engineers. So it's nurses, engineers, and then us. But we do have a kind of a high, there's a high number of folks across the country who do view us as very honest and very ethical. And that gives us this opportunity, for better or worse, to serve as advocates in various policy fora. There is a kind of a privilege that we have that we can harness to be able to effectively message to not just policymakers, but also the public in general, and folks outside of the healthcare sphere as well. When we wear a white coat, there is, some added, there's an added responsibility and an opportunity to be able to effectively message the different health policy issues that we're very concerned about. Next slide. And this is true really across the aisle. So this is a recent effort that was done by Frank Luntz. He's a Republican pollster and has famously coined the term death panels around the Affordable Care Act fights that led to various concessions being made, and also kind of a defensive strategy from the opposition in response to this type of messaging. He's using his expertise, though, in kind of imaging, messaging, and framing to be able to overcome issues around vaccine hesitancy in particular. So he ran a focus group of around 19 people who all voted for President Trump or who voted for Donald Trump in the 2020 election, and then also had expressed some hesitancy about receiving the COVID-19 vaccine. And he had various folks talk to them. He had politicians, former ex-presidents. He also had folks who were from the faith community, those who had actually suffered from COVID-19, and then also physicians, including Tom Frieden, the former CDC director. And what was really interesting is that at the end of the focus group, he asked them, you've got to choose Donald Trump or your own doctor. Who's going to have a greater impact on whether or not you get the vaccine? And all 19 of them said their doctor would be more influential, which he was surprised by, and many others who actually tuned into this were also surprised by. But this just shows kind of the ability that we have, not just in the exam room, but really even in larger spheres, to really influence health policy and to advance, advance regulations, bills, things that we feel will help make healthcare better for our patients and really make their lives better in general. Next slide. And of course, in doing so, it's also important for us to be cognizant of who our audience is. The way that we talk to policymakers in terms of, speaking to their interests, in terms of being able to convince them about a certain policy, is going to be very different from how we talk to other healthcare professionals or the medical professional societies that we're a part of, as well as patients. But all three of these audiences are really important to kind of think about, but also to kind of effectively frame our messages around. Policymakers might be driven by things that are specific to their own district or their own states. So having figures about the impact of a certain regulation on one of their pet projects might be something that we should keep in mind. For other healthcare professionals or medical professional societies, there might be considerations on the clinical end that we could be able to speak to. And then, of course, for patients, the idea of being able to take very complex medical issues or very complex really health policy issues and distill it down to why they should care about it and why it's important and how this could make things better is also something that we can, if done well, can be also very effective in kind of changing public opinion. And next slide. So I'm just going to walk through kind of an example from what we do on the Drug Affordability Action Team here at DFA. Drug pricing has been an issue. Drug pricing has been an issue across the board for both Republicans and Democrats, and really last year before the pandemic really became an issue that was in front of Congress with potential policies that were going to be passed. And one of the things that we had been looking at is the various polling data that was available in terms of what the burden of prescription drug pricing or high drug prices were on our patients. And thankfully, we had great resources to look to. One of them is this, where this is from the Kaiser Family Foundation. They did a national poll where what they actually found is that 1 in 4 patients actually were reporting difficulty affording their prescription drugs. And then on top of that, another kind of easy to remember number, 3 in 10 Americans actually said they weren't taking their medicines as we were prescribing them, either having to get an over-the-counter medication, cutting their pills in half, or skipping doses, or taking or not filling their prescription at all. And so taking these types of figures and being able to distill down to its main points, 1 in 4 patients not being able to afford their drugs and finding it difficult, and 3 in 10 patients not being able to take their drugs as we prescribe them, were figures that we really wanted to put out there in terms of public messaging, especially to policymakers when they were considering drug pricing policies and whether or not they should support certain legislation. Next slide. And of course, with the COVID-19 pandemic, this has also worsened drug affordability. And thankfully, we also have some great data on this. This was a report that just came out earlier this year from GoodRx, where they asked folks in the last year how COVID-19 has affected drug affordability. And what they found is that patients who had been reporting difficulty had actually increased. Now we had about 40% of patients who were reporting difficulty affording their prescription drugs. And on the right side, they also found that the prices of prescription drugs are also affecting people's abilities to afford basic necessities, such as food and shelter. And so these types of kind of facts and figures were things that we wanted to put out in public messaging, that the fact that the COVID-19 pandemic had also caused other collateral damage in terms of worsening drug affordability. Next slide. So when we got together with our national steering committee and looked at all these facts and figures, we wanted to really distill it down to a couple of key messages. And so we thought about their different audiences. For patients and other physicians, one thing that might resonate is kind of the contrast. While we've been seeing our patients suffering during the pandemic, having lost loved ones, their own lives, and also livelihoods, the pharmaceutical industry actually thrived. In fact, they actually raised the prices of hundreds of drugs all above inflation within the last year and continue to make record profits. They kind of ran business as usual. And then for policymakers, one consideration that we really want to hit on was, there's obviously concerns about the economy being able to recover from the pandemic, but there was another piece of collateral damage from this. In addition to millions of people losing their jobs and also health insurance, they also had an increasing inability to afford the medicines that we prescribe them. And on top of that, as a budget consideration for policymakers, especially at the federal level, thinking about things like Medicare Part D as the world's largest purchaser of prescription drugs, knowing that every dollar that's going to be spent on paying for these high priced prescription drugs would be another dollar that would not be spent on building back better. A phrase that we've heard, in President Biden's campaign, but really across the board from various politicians in talking about the COVID-19 recovery. And this would be an influential way to kind of message around drug pricing, especially as COVID recovery bills are being considered. And now we're coming to a head where, one of the infrastructure bills will include provisions around prescription drug pricing, that at least what we're hearing from Congress and the White House. Next slide. Of course, as a part of messaging, we also need to anticipate counter arguments. On the right-hand side is an example of kind of the aggressive nature that we're hearing from the pharmaceutical industry. They're actually highlighting and using the COVID-19 pandemic and their role in developing vaccines and treatments to actually effectively message against any sort of policies that would curb high prescription drug costs. The right side is actually a full page ad that ran in an Oregon newspaper. And we're seeing this replicated across the country right now as different states are actually considering proposals to curb skyrocketing prices of prescription drugs. And then also at the federal level, where there's actually bills that have been introduced in both the House and Senate to regulate pharmaceutical companies. And the text I know is a little bit hard to see, but essentially what they say here is, why would you want to interfere with our job? We actually did such a great job with COVID-19 vaccines. You're going to hurt seniors. You're going to hurt folks with chronic conditions. Don't threaten access to innovative treatments and vaccines. And on the left-hand side, we're actually seeing that some of this messaging is actually working. Public approval of the pharmaceutical industry before the pandemic, when a lot of these drug pricing proposals were being strongly considered, was low. And that actually helped a lot of the momentum that we had around policy in this area. But now, as of February of this year, we're actually seeing a huge uptick in terms of public perception of the pharmaceutical industry. And we're seeing this reflected across social media, especially in thanking a number of these companies, despite a significant amount of public investment going into COVID-19 vaccine treatment and vaccines and treatment research and development. Next slide. So on this slide, we wanted to really look at the complexity of prescription drug pricing and really where the role of patients were. You can see that our sick patient, our jaundice patient here, just as an example, has multiple interactions with the prescription drug pricing system. Through taxes, they actually help fund federal agencies such as the National Institutes of Health that actually undergirds the development of almost all FDA approved drugs that are on the market. They also pay insurance premiums to be able to access prescription drug plans on the right-hand side. And they also pay at the pharmacy counter. And so the question became, why are our patients paying multiple times over for their prescription drugs? Next slide. And so we decided to reframe this. So instead of kind of crediting the pharmaceutical industry for their role in innovation, and knowing that actually it was really through public support that we're seeing innovative, transformative medicines and COVID-19 vaccines really on the market, we started, looking at different ways we could message this. On the left-hand side has an example from a recent campaign that we have with Oregon, where there's a prescription drug affordability board that's being considered. It just actually passed through the Senate Health Committee, thanks to the efforts from various DFA Oregon members. And a part of that, the messaging that we had for both policymakers, but also the public, was the fact that all FDA-approved drugs that we have on the market actually had their development supported by the NIH, a taxpayer-funded federal agency. And on the right-hand side, we've also been doing some writing, op-eds, and other policy pieces where we actually point out very concretely the role of patient and public investment towards these novel treatments and vaccines. And so this was a way for us to actually argue against the narrative that the industry had put out, that they were solely responsible for innovation, when in fact our patients are the ones that are ultimately the primary investors for these vaccines and treatments. Next slide. So just, I think it's missing the video here, but if you go to our DFA YouTube channel, you'll see a video that one of our National Steering Committee members put together, Allison Case. She is a family physician who's from Indiana and really spoke to her experience in terms of having patients in the exam room tell her that they can't afford the prescription drugs that she was prescribing them, the medicines that they need to live a healthy life, and why that's important in terms of thinking about policies that are already being proposed to regulate the pharmaceutical industry. I highly encourage you guys to watch this as an example of how we can take our experiences, seeing these injustices in our own exam rooms, and translate it as ammunition to actually push forward policies that really matter for our patients, and as a way to really get the message out to the general public. I'll stop there and we can transition over to Justin Mendoza. So Justin is the advocacy manager for US Healthcare for Partners in Health. He's extensive experience in healthcare advocacy, organizing for other major consumer organizations, including Public Citizen and Families USA. Justin is just delightful and an expert on messaging, framing, and also winning campaigns, and excited to hear from him about his strategies to do so.
Thank you so much, Reshma. And I hope folks don't judge that I left March on my slides rather than April, despite it being April. But, you know, 2021 is a weird year. All right, so I'm delighted to talk with you all tonight and just thank you all for inviting me to your first Advocacy Grand Rounds. I think that this is a really exciting opportunity for folks to really connect with and dive into advocacy and create more physician advocates out there in the world for all the reasons that that Reshma was just sharing with us. Your voice is incredibly important. If we can move to the next slide. Just briefly, I wanted to let you know a little bit of where I'm coming from. Partners in Health, we're a nonprofit organization grounded in social justice and healthcare delivery. We work in countries all over the world to build health systems by working in partnerships with the local communities there and governments that want to actually build out stronger healthcare systems that work for the poorest in their society. And on the next slide, we actually, in response to COVID-19, launched our US Public Health Accompaniment Unit, which is really aiming to build out a stronger healthcare system in the US, focused primarily on our public health system, which has been decimated after decades of disinvestment, but also to really focus in on health equity and get to the last mile, especially with communities of color around the US. To the next slide, please. In following suit with any physician who presents at a Grand Rounds, I wanted to clearly state that I have no financial conflicts of interest with regards to the content presented here either. I do speak on behalf of Partners in Health here on this call and as an ally to Doctors for America. And to the next one, please. Perfect. Actually, we can go one more. Thank you. So one of the things that I want to get across today and talk with you all about is how you can build your messaging campaign around actual power. And by power, I don't mean electricity. I mean the ability to get decision makers to do what you want. In this case, in the case of physicians and folks advocating on behalf of patients, the thing that you want is better healthcare, better outcomes, lower drug prices, all those other things that you all believe in and advocate for. So I want to teach you just a little bit of the way that I look at advocacy and how we think about this. So first, I like to start here with this foundation in power and these 5 forms of power, which really briefly are essentially ways that people really go out and try to work with or influence the actions of decision makers. First is influential power. Influential power is probably the most generic form of power that there is, but it's really conferred when you have a relationship already with a decision maker. If you can look in your cell phone right now and find in your top 5 contacts or somewhere within there, a number of folks who are elected officials, if any of you have President Biden's phone number or something like that, then you probably have influential power. You can probably pick up the phone, call that person, and work your relationship to try to get decisions made that can help your patients. That's amazing, and we're glad that you're in this fight with us. The next form of power is people power. This is probably the one most people think about. This is the power to churn people out to elections. This is what changed the tide in Georgia, is mobilization and getting folks out there to vote and to do things. Or it could be mobilizing doctors across America to fight for healthcare improvements. People power is really one of the ones that we all like to tap into when we think about advocacy the most. It's why marches and protests matter to you. Authority power. This one's conferred by title. So if you're advocating for something within your healthcare system, this is the power of your CEO. This is the power of the Dean of Medicine. If you're advocating for something more externally, this is the power of the Office of the President of the United States. This is really something that's few and far between by the nature of authority power. Money and market power are all about fueling or really wielding the economy. In these cases, we're talking about market power being massive interests that can actually affect the overall economy by how they act. Imagine like an Amazon or another large company that employs a lot of people, that sets a lot of standards for labor, that sets prices. Money power might be more direct. It's people who donate to individual candidates, or it's the power of individuals to deny money to an actor in the market. So a boycott, something like that. Anyway, I raise these so that you can have a little bit of a grounding as we go on to the next part of the conversation, the next slide here, where we talk a little bit about how you might build power. Within those 5 domains, or the examples I use, there's other domains of power folks like to reference, but within those 5 domains, how you might start to think about influencing a decision maker and using many of the tactics and strategies that Reshma outlined from the work that DFA is doing around drug access. It's not, just an idea that spurs out of nowhere to counter your opposition's message. It's rooted in power. It's rooted in the ability to counter that message and why it's so important. So on the next slide. So just to start, the first thing that you want to think about always is, who is your decision maker? Identifying that decision maker is key, and it's always a person. It's never a body of people. It's never the full Congress of the United States. It's never a full committee. It's going to end up being one person, or, working collectively with other folks in your movement. It might be 1 or 2 people, but you're responsible for one. That decision maker is going to be the person that you need to build your entire strategy around, and eventually your message around. And next slide, please. So the first thing I want you to do when you're thinking about advocacy, before you develop your message, before you determine how you want to talk about the issue, is take a look at where that decision maker sits. I suggest grabbing your 5 vaccinated friends, or doing this over a Zoom party, but literally put the decision maker's name on a wall and start to map out relationships and folks that you can find out are connected to them. Their business associates, their advisors, their staff, some of their family members and friends, or maybe, folks who've donated to their campaigns if they're an elected official. You can find most of the stuff online, and if they're an elected official, opensecrets.org is your best friend for finding this information. Next slide. Once you map those relationships physically, that they exist around the decision maker, Then you go into this. This is a power map. This is the bread and butter of community organizing. It's one of the oldest tools in the book. But you quite literally create an X and Y axis where on the Y, you're looking at influence on your target. Your target is at the very top, and then someone who absolutely has no influence on their decisions is at the very bottom. Then on your x-axis, on the left side, you've got folks who are very much in opposition to your stance on your issue. And on the right side, the high end of the x-axis, you have folks who are really on board with your issue. Honestly, it's you. It's your opinion right there. So then with this, you can start to look at different kinds of actors who you've already determined have a relationship. Here I've mapped out a bunch of hypothetical folks like a labor group, a faith group, a university in the area, a business associate, and a close friend of your target. Next slide, please. Then we get to do the fun part. This is where you look at, you actually take those folks that we've put onto our power map and start to think about how you might approach those folks. So for the people who are closer to your view, that are closer to agreeing with you, you're going to start by taking a look at who they are, name them, figure out their relationship to the target, figure out their interest in your issue, and what form of power they have over the decisions that your target makes, that your decision maker makes, and then build a plan. Sometimes the plan is super easy. It's exploit a personal contact. Sometimes it's something like we have here, like building out a joint meeting with someone who's pretty close to the same idea, but maybe has a different version of power that they can wield. Or it might be something that's really direct, like asking them to join your coalition or your campaign. And you can really start to build that out and see where it best fits. Next slide, please. And then really importantly, just as Reshma pointed out with the examples from DFA's work on drug pricing, you want to look at your opposition. You want to see some of these groups that are going to be on the left side of that power map we looked at earlier, who might disagree with you and who might hold different forms of power. And you want to map out the exact same domains and build a plan. Sometimes that plan results in counter arguments. Sometimes it results in a direct head-to-head debate. And then, of course, sometimes you can figure out how to actually work with your opposition on similar issues that won't detract from your mission. So you can find different ways to work that through. On the next slide, please. So I want to talk a little bit about what this looks like in action and give you a little bit of a taste of some of the tools that we've used in building a campaign ourselves. Next. So first, at the beginning of the COVID-19 pandemic, and really, if you look historically at public health systems over the last 30 years, public health programs across the country have been decimated. Funding has decreased year after year. Programs haven't been able to hire. And we've seen the results of that. The results of that is an unmitigated pandemic where hospitals are overrun and everything else. All of that's old news, especially to medical professionals. At the same time, community health has never really been a core focus of funding or support across the US. So we came together with other organizations. You can see the list on the right in last fall to launch Public Health Jobs Now, which is a campaign to build a public health core to build a stronger, more equitable healthcare system, or public health system rather, in the US. And you can see some of those same types of groups that I was mentioning earlier are part of the signatory organizations that launched this group, like a major union, people working with folks who are laborers and working class. You have healthcare experts paired with public health experts and legal experts and faith groups, all coming together to build this coalition and campaign, specifically because we knew that we all tap into different forms of power and could use that while working together to try to advance the cause. Next slide. So first I'll point out PIH's actions on this. What we did was we figured out, one, how to communicate this to our constituency. We wrote a Q&A that talks about why we care about this. We put it out on our list. We made sure our donors and our action takers knew what we were doing. We wrote up and did our own assessment of where the need is, why we need this public health workforce, and what that workforce should look like, and published a white paper on it. And then we've done opinion pieces. Our CEO wrote an op-ed with Senator Gillibrand, who's an author of a piece of legislation that really aligns with our mission and goals here with the campaign. In addition to this, we also led sign-on letters that were directed at decision makers in the Senate and the House. But I actually don't have a good visual of that one. But we also led sign-on letters with 36 signatory organizations advancing the policies that we cared about. Next slide, please. In addition to that, of course, because we formed a campaign, we have partners. And those partners brought many different strengths to the table, including their own sign-on letters, their own individual outreach, which of course don't have too many visual pieces to them, but these two do. Our partners hosted an interactive conversation, much like this one, online, which was attended by a large audience and featured a video from the senator talking about her legislation and how that fits into our overall mission for a public health workforce. And then at the same time, some of our members were able to get faith leaders in Utah to write an op-ed talking about the importance of public health response to this pandemic in a very different setting than most of us. So we looked for both geographic reach and multiple types of events and things to get the word out and build the movement. Next. And finally, as a really important piece of this, we built champions along the way. Senators Gillibrand, Bennett, and their co-sponsors on the legislation that we worked on an op-ed about actually worked really hard to get language included into the American Rescue Plan Act, with our coalition backing them all the whole time, so that we could step together and give them the ability to push as decision makers for the White House to take the right actions and for the rest of Congress to take the right actions for this funding to exist. And this resulted in here, this is a press release that they put out, but they also sent in a letter that explained the intent of legislation that they had helped draft. And this is really the kind of exciting part where, you've worked on getting decision makers on the same page. You've helped pair that with good data, a good narrative, good letters, and other pieces that you can bring together. And then your coalition is able to walk with those decision makers to influence other decision makers so that you can finally win the big thing. And of course, since this was the American Rescue Plan Act, the bill's just recently passed. So we're still looking at implementation, which will come soon. Next slide. Oh yeah, that's everything I had there. So I'll pass it back to Reshma, but big takeaway for me is just that if you do this well, you do it working together, you can win on campaigns that really change the lives of folks around you.
Thanks so much, Justin. And that's really amazing, the work you've done, obviously with the American Rescue Plan, but now looking forward towards implementation of the amazing policies that you put together. Next, we're going to have Dr. Josh Sharfstein. Dr. Josh Sharfstein is the professor of the practice in health policy and management at the Johns Hopkins Bloomberg School of Public Health, where he also serves as the vice dean for public health practice and community engagement. He also directs the Bloomberg American Health Initiative there as well. He served in various roles at the city level as a former health commissioner of Baltimore, at the federal level as a principal deputy commissioner of the US FDA, and at the state level as the secretary, as a health secretary of Maryland. We're thrilled to have him come speak with us today.
Thanks so much, Reshma. Thanks for having me. And looks like we have some slides here. And you've heard the each of us are talking from different perspectives, but I'll be the perspective of the one-time target of advocacy, and talk about a little bit a perspective that I have about a kind of advocacy. It's not every kind of advocacy, but a kind of advocacy related to marshaling information, data, stories, and presenting it effectively to policymakers. So, and I'm emphasizing the written word today because personally, I think that writing is just incredibly important for advocacy and efficient and efficacious advocacy. Okay, so why don't we go to the next slide? So why do I care so much about writing? Well, personally, writing has been very important to my career. Sometimes I, don't count on the ability to be able to say everything perfectly as I'm just extemporaneously speaking, but I like being able to take some time, formulate my thoughts, and try to be persuasive. It allows for clarity of expression. It allows for really listening to what people are saying and trying to persuade them. And also there's a permanence to it. And so many times there's been all this tumult, meetings, phone calls, and what's left at the end? It's usually something written. And if you can write effectively and clearly, then your ideas, your perspective, your framing can be very helpful to how people think about different issues. Next slide. So here are a few principles to consider. This is when you're writing for advocacy, you're not writing a mystery novel. You're not trying to sneak up on people. So you're like putting everything together. At the very end, you're going, and that's why, that is generally not a good strategy. People want to know what you're there for. And in writing, you should say it up front, summarize it in the middle, have a conclusion at the end that summarizes it, have a table that summarizes it. You're basically really emphasizing your points. People should have no doubt what you are asking for. I recommend a direct, persuasive, accessible tone, not too flowery language. I try to avoid the use of adjectives. I know that sounds kind of crazy, but I go through and I ask myself, is every single adjective needed? If not, I take it out. I prefer understatement, not overstatement. And I say that because when you read a letter that has like 4 adjectives thrown together, and people are clearly expressing how unfair, comma, unjust, comma, this, and that, they're calling so much attention to themselves compared to the actual issue that they're raising. To me, it hits with more impact if you lay out a set of facts that's just devastating, and at the end you say, this is not right for health, or something that's really basically simple. To me, that can come across just so much more forcefully. DNUA, everyone on the earlier call knew what this was. So maybe we'll just pause for a second to see what the people on this call are. No. What does DNUA stand for? Reshma got it immediately the last time. Let's see. Richard Bruno, I'm asking you. You're going to say hello. You got to answer. What does DNUA stand for? Did we lose Richard? Oh, so close. It's a good one, but it's actually do not use acronyms. Do not use acronyms. When you're writing for advocacy, spell out every word. I don't recommend aardvarks either. I wonder if that's the Marsha Zuckerman I know. But in that case, do not use acronyms. Exactly. Acronyms are like a secret language people use. I don't even use CMS. I write it out. I don't even use FDA. I try to avoid every single acronym. Sometimes I'll let myself use US, but I cannot tell you how many times people bring to me advocacy, writing in one form or another, and it's like an alphabet soup of acronyms. And I literally go through every single one, and every time I rewrite it and I write them and I go, please don't make me do this ever again. Can you use acronyms after you've ever explained what it is? DNUA, never use acronyms in writing. Not the first time, not the second time, not the third time. That is the rule. If there are exceptions, I have not progressed to the level where I've learned the exceptions. I avoid acronyms completely. I don't like making people refer to other paragraphs. It breaks their way of reading something. I like them to be in the moment and really understand the argument. Understatement, not overstatement, I talked about. Let's see. Also, things should read well. Shorter sentences, clearer thoughts. I'm a big, I assign the Elements of Style in my class, great book. I also like things to look good. And, the corollary to 90% of life is just showing up is that 90% of writing is how it looks on the page. I don't think that's really true, but it helps. And I could tell you, I'll give you an example. If and I mean, I've never studied this, but I have a complete belief that this is true. I'm looking at Reshma here. This is a little looser than our earlier conversation, but it's 8 o'clock, it's past my bedtime. So, if you were writing a letter, say you're writing a letter to Secretary of HHS, and you're sending it around, and it just says at the top like 2XXX, and then, you know, or 2 and then a little blank line, and then it just jumps right into the letter, and it's all jumbled up, and you have kind of like the footnotes, just sort of, you know, either links or I'll add a note here or whatever. It just looks like it's not ready, and you send it around, you go like, hey, I wonder what you guys think about this. People react to it one way. If you put the full address, you know, you put draft at the top, the date, the, you know, who you're writing to, their full address, and you actually do a nice job with footnotes, people just literally react to it differently. They think it's so much more serious, they take it more seriously. You can, you know, maybe when that gets studied in a randomized trial, it won't be the case, but I will be surprised if that's the case. Next slide. So what not to do? And these are all things that I've heard from different people. So what if all the facts and what I wrote aren't accurate? I know you agree with the policy. That means I'm not going to trust you. You know, I won't trust you about the strategy. I won't trust you when you tell me somebody told you something. If you won't stand behind what you wrote, and if it's not accurate, I'm not going to trust you. And that's not a good relationship to have with an advocate. And oftentimes I've been in situations with people, I do agree with them and I don't trust them, you know? And so that's just, you know, the way it is. I think it's really important to be accurate. If someone catches you that you've made a mistake, say, I made a mistake. Don't say like, it's not important, it's not important. You know, the important thing is the goal, because then people won't trust you on other things. It's complicated. If you don't understand what's there, you'll have to trust me. Many times advocates come in, they've got their acronym laden piece. They understand this. You don't understand this. They don't take time to explain it to you. And, you know, that's not an effective way to go about writing. Writing should be so that the person that you're writing for can really understand it. And then figures are complicated. Some people really take to heart a single picture is worth 1,000 words. That's only true if it's really well labeled and really makes your point. And if it doesn't, I cannot tell you how distracting it can be. Very distracting. So I guess I can tell you, very distracting. Okay, next slide. Just a few forms of writing. Sometimes people have like the spinal reflex of op-eds. You're going to write something, it's got to be an op-ed. And there's a way to do op-eds. You do a lead, you have a paragraph that really explains what you're trying to do early on. You have really clear and sensible arguments. But I would urge you to think outside the op-ed, not just letters to the editor, but a letter to a public official. You can write a whole letter. It can be 5 or 6 single-spaced pages. You could have 20 or 30 footnotes, but it's really clear. You have a nice summary at the beginning. You have subheads. You have, if there is a figure, it's totally well labeled and clear, and a concluding section. And then you can take that, and that becomes the basis for people really understanding your position. You can post it to the website, you can give it to a reporter, you can use it for whatever. And it is not this shorthand 600-word op-ed that you had to cut down to get into a paper, and really just raises as many questions as it's trying to answer. Whereas you have a really comprehensive perspective on what you believe, can be really effective advocacy document. And then I also would say, don't forget official submissions like comments or petitions, which can force agency action in different ways, and really write them well too. Next slide. Here's some examples. Here are a couple op-eds. I know they're just op-eds that I've written recently on COVID. And, you know, we picked this because we really wanted to reach a large audience quickly. One was about the vaccine inequities in Maryland's vaccine rollout, saying clearly the governor needs a plan to fix them, and we said what we thought he should do, and Maryland has definitely moved in that direction. We also tried to call attention to how we were not doing what was necessary to really open schools as opposed to bars, and that was back in June, and it was unfortunately prophetic. You know, we talked about the importance of opening schools and what needed to happen. Next slide. This is an example of a letter that we wrote to state leaders in Maryland. It was a fantastic public health student drafted it. It was about 4 or 5 pages, or I think, and it went through all the evidence that we could find on why it was important to add eviction protections in Maryland. And she did a great job tying it to health from all these different conditions. There were all these footnotes, and it really conveyed the full gist of the medical, you know, evidence. And it was such an impressive letter that she wrote that the Baltimore Sun wrote an article about it. It was really widely cited on social media, and not soon after, the state announced a whole set of eviction protections. Next slide. This is a petition that I wrote with some pediatric experts when I was health commissioner that led to the withdrawal of all cough and cold medicines for children under 4 in the United States. And, you know, these medicines were dangerous. They had no evidence for them. And this was the opening paragraph. We said, under the law, they're classified as generally recognized as safe. Yet, for the treatment of cough and cold for children under 6, these products have not been shown to be safe, have not been shown to be effective, and are not generally recognized as safe and effective, which is a legal standard. So, I mean, we just went through methodically, directly, clear language, and that was, in the end, persuasive to the industry and to FDA. So I think that might be it. So work on your writing. It's such an important skill, regardless of what you're advocating for. Thanks. Look forward to the discussion.
Yeah, thanks so much. We can stop the screen share so we can see folks. But we have a couple of questions already, including one of the ones that came through the Q&A. So we can start off with that. Someone with the initial ZK, I'm assuming, wrote, who do you write petitions to? So if folks want to jump in, and we can offer some examples from DFA where we've written petitions and comments as well.
Well, administrative agencies often have a petition process, and there's a format for the petition. Food and Drug Administration, if you petition the FDA owes you a response, or you can take them to court. So it's an official way of, you know, engaging with an agency. And for example, I work with some students at the School of Public Health and a whole bunch of health officials at this local and state level saying that FDA should, on a petition, for FDA to add a box warning on all opioids, warning about use with benzodiazepines, and on all benzodiazepines with use about warning for use with opioids. And that was like hundreds of drugs, and they basically granted the petition. And those warnings are on all those medicines now.
And I would just throw on, just add in outside of agencies and administrations, which those are probably the more effective petition than what I'm going to bring up in many cases. But you can also always petition an elected official. And I do mean any elected official. The important piece, when the kind of petition I'm talking about is the kind where you want as many signatories as possible of people, either if you want it to be from medical professionals, as many doctors as possible, or nurses or other medical professionals, so you can give that perspective of medical professionals think this, or as many general voters as possible if you're going for an elected official. And the reason, you know, you go for big numbers on a more general petition is because it's more impressive. Quite literally, someone will look at something that has hundreds of folks on it, or thousands, versus, you know, 5 or 10. Advocacy is always a team sport when it comes to that. So that's a big piece of it.
Yeah, I would just say that I think there are different types of petitions. So sometimes you want to write a really detailed petition, and it's just not that easy to get 1,000 people on a really detailed petition. It's not just to express a view, it's really to go into it. And it's the people that you pick are really the knowledgeable people. When we petitioned the FDA on cough and cold medicines, we had the top pediatric pharmacologist and the top pediatric toxicologist in the country signing. So I didn't, you know, I wasn't trying to get 1,000 pediatricians to sign. I wanted really good people that allowed me to call reporters and say, we have the top experts on this. This is a great story. And eventually that got us to a huge story at the front page of the New York Times, which really put a lot of pressure on the agency.
Those are fantastic examples. And I will just say, as an aside, you know, the wonderful thing about joining Doctors for America and being a part of an organization with other folks is that there is a platform for us to be able to monitor petition opportunities and also to be able to submit them. So, you know, we've recently done this. One example's in the chat, but also in relation to drug pricing issues, and would love to have more folks on board across a variety of things that DFA works on. Another question we got is, when sending an email or communicating in general to my state representatives, how in depth should I go with supporting evidence when describing my support for a particular piece of legislation?
I would say the question is how in depth to go.
How in depth, yeah.
The right level of depth, I would say. I mean, it's hard to say. I mean, you could chart the, you know, a certain level, like I support this legislation, not that, you know, convincing, but, you know, by the 25th page, you're going to lose interest. In general, I think like 3 to 5 points is like a good attention span for someone in a single, you know, sitting. I recommend when people testify before Congress, for example, that they literally, you know, count out the points that they're making. I really have 3 points for you today. And in general, I think that a lot of, you know, elected officials and staff, they think in terms of numbered bullet points. And so I think if you were supporting something, I would say, this is a good piece of legislation. There are 3 major reasons, and I underline them so they really understand what those are. And, you know, depending on how long you want to make it, you could explain your reasoning for them. You know, this is going to help my patients who, you know, who are in this situation. For example, I just saw a patient, blah, 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 blah. Number 1. Number 2, it's going to, you know, make it easier to develop, you know, the next whatever we're talking about, you know, it's going to lead to better policy changes in the future, whatever you'd want to say. But, you know, these 3 things, what I wouldn't do is send a huge block of text, you know, that just makes people go like, oh boy, here's the big one, you know, and you're forcing people to do a lot of extra work rather than 1, 2, 3 really clear.
I'm just going to jump to this related question. So if you're sending a letter to an elected official, is it better to send it to someone on the relevant committee or someone who is your representative? And I'm curious because I know, Josh, you've been in the position of being a staffer in Congress, and what you would respond to, and then Justin on the other end in terms of being a lobbyist. Justin, why don't we start with you and then we'll go to Josh?
Okay, yeah. I would say, you know, in general, you want to start with your own representative. But if you're speaking on behalf of an organization or organized doctors or your profession and reaching out with an expert opinion and kind of professional thought on this, and you have evidence, the relevant committee is a really smart way to go. I would give the example of, like, if I just wanted to say to my legislator, well, I live in DC, so my legislator doesn't have a vote. But if I was going to say to my legislator formally when I lived in Michigan, that I would love for you to support this legislation that's coming up for a vote, I would reach out to that legislator as a constituent. But if I knew that the real concern was a policy detail in, like, I don't know, choose like surprise medical billing legislation or something, and I could say with authority that I have an experience and understand it, I might send that to the legislative office of like the committee staff or the committee chair or someone else who's there. The hard part is it depends on timing. If there's an upcoming hearing, the committee needs to hear things. You know, letters can be put into the official record and things like that. But if it's just kind of a general, it's a Wednesday and you want to send in an opinion on a bill, it's almost always safer to go with your elected representative.
Great.
I would say in my policy class that I teach at the School of Public Health, we have an entire assignment on finding the right policymaker. You know, what is the right person for what you're trying to do? Who do you want to engage? And we have the students write a whole paper about a particular policymaker. What is actually in their span of authority? What are the formal and informal constraints? Nobody is omnipotent in the world, you know, so what, or at least not in our general policy world. So, maybe it looks like they can make a decision, but what are the things that are keeping them from making a decision? When I was at FDA, for example, we might have been interested in making a decision, but there were all kinds of forces outside of FDA that were making it very hard, even within the administration, to make a certain decision. And when people just attacked us for not making the decision, they were attacking maybe their natural allies on a particular issue rather than trying to help us. So really trying to understand the formal and informal constraints that exist. And so it would really depend for me, the answer to that. What are you, trying to accomplish? And, make sure you ask for things that people can really deliver. The easiest thing, and I've been in so many meetings where I sat down and go like, it is so great that you're interested in X. I have nothing to do with X. So I will give you the address of the person who's totally responsible for that. And here it is, so you don't want to be in that situation necessarily.
Yeah, that's great. So we did get a question about recommending, do you recommend any specific platforms to send in op-eds for beginner writers and advocates? I will just say from the DFA perspective, we do host op-ed happy hours where we're working with physicians with op-eds and helping them to craft it. Josh kind of mentioned there is like a format for an op-ed, especially with the lead, getting your main point across, and really anticipating the counter argument, your to be sure statement as a part of that. So we do host those types of sessions on various issues. But I'd be curious for folks from you guys to hear how you talk to colleagues, how you approach op-eds, your students, Josh, in terms of that form of writing, how to start getting into this.
Usually I try to have students write longer letters first. I just think the letter form is so underutilized, and you really can express a lot more information. And you can often, if it's a good topic, get a lot of media attention to really well done letters that other people are writing about it. So I know I'm not answering the question directly. When people really are begging me to write an op-ed, I will help them. Yeah. And we do have some op-ed trainings, but I think that unfortunately people have too much of a reflex about op-eds. Op-eds generally, blow down the street the next day. There are not that many, in discarded newspapers. There are not that many op-eds that have a lot of staying power. Sometimes it's really the right thing, but I think it's, there are other ways depending on the issue, and really to consider all the different options, what I would say.
And then Justin?
I completely agree, 100% on every single thing there. Op-eds, I mean, I wouldn't have said it with as much eloquence. I think when I think of op-eds, I think of them as an overdone media form quite often in terms of advocacy, because it is the first thing that pop into people's minds. Even the letter to the editor can be more ubiquitous, more powerful, because you can get it at a smaller, more local, more targeted paper. Where you might be able to put something out and it takes, 150 words to put a small opinion, like one opinion, not 3 points in this case, but just one out there. But I do think, direct letters and things like that are far more powerful most of the time. If you are going to go for an op-ed though, really the best way to do it is to go to a DFA training, find training from someone like Josh. There are no good web platforms that teach you how to write an op-ed and submit one for you, because it's supposed to be coming from your view. So anytime an editor, and I've talked to many letters editors, I've published op-eds myself, anytime an editor gets one that comes from a forum, it goes right in the trash and they can tell. So you really do need to have just go to one of those trainings, learn how to write one. And then how to submit to that individual person at the right op-ed desk if you go down that route. But I absolutely agree with everything Josh said. There are so many other pathways to get the word out there.
Thank you both so much. This was fantastic just to hear about the different ways to effectively message our interest in different health policy issues. I'm going to pass it back to Justin Lowenthal, who's going to be speaking to this continued series that we're having.
Thanks, Reshma, and a huge thank you to Josh and Justin for coming for both this session and the session at 1 p.m. and really sharing some incredible wisdom. I learned a ton. And thank you to all the attendees for coming, and for those who expressed interest in this series. We're really trying to build it into something that medical students and physicians everywhere want to attend and really can get a lot out of. So be on the lookout after the event for messages from us with links to the recordings of these events, links to the slides, and actually a really helpful handout of the best tips from our speakers, as well as a link to a brief survey. And we really hope you'll take just a couple minutes to fill that out. Give us your ideas on this series, and hopefully give us some feedback that we can use to make this series even better in the future. Mark your calendars for our next event. Our next event is scheduled for May 13th. We're tentatively scheduling these for every second Wednesday of the month. And so the next one will be on May 13th, the same times, 1 p.m. and 8 p.m. Eastern. And that one will be focused on dismantling racism in your daily practice. It's really a privilege to have Kelly Butler, who is a medical student, fourth-year medical student at UC Irvine, and a huge advocate and activist in the anti-racism in medicine space. She'll be moderating, and our speakers are to be named, to be determined. So follow the link in the chat or in the follow-up to pre-register for those, and we'll follow up with more details as that approaches. And in the meantime, have a good evening. Thank you for coming, and we hope to see you again for a future DFA Grand Rounds and DFA events generally. So thank you and good night.